Good afternoon, everyone. This is Marcy Ravitch, the director of the Massachusetts Child Psychiatry Access Project. I want to welcome you to the second in our series of clinical conversations that take place the fourth Tuesday of each month from 12:15 to 1:15. Today's topic is managing challenging behaviors in young children with a focus on the PPP positive parenting intervention. Our presenters today are Dr. Barry Sarvet and Alexis Davis, LICSW. A few housekeeping things before we get started. This session will be recorded and will be available on the MCPAP website at www.mcpap.org. There is going to be ample time for discussion and case examples after Dr. Sarvet and Ms. Davis are done presenting. You can either type your question into the chat box or the question box, or raise the little hand, click on the hand button in your toolbox on the webinar, and I will be able to unmute you so you can ask your question during the discussion period. We're also aware that some of our other accredited PPP providers are on the call, and I want to invite you to participate in the discussion and raise your hand so that you can add your experience as well. Want to let everyone know that you're going to receive a very brief Survey Monkey. I think it's 2 or 3 questions after the presentation, and we hope that you'll take just a minute to fill that out. We appreciate your feedback as that helps us improve our presentations moving forward. Our next clinical conversation is going to be Tuesday, January 26th, and the focus of that presentation is going to be postpartum depression screening in the pediatric setting. So I'm going to introduce our presenters and we will get started. Dr. Barry Sarvet is a board-certified child and adolescent psychiatrist who served as the medical director of the MCPAP Bay State team since its inception. As of July 2015, he now serves as chief of psychiatry at Bay State Medical Center. We are privileged to have Dr. Sarvet continuing to serve as the statewide medical director for MCPAP as well. A nationally recognized expert in child psychiatry consultation, Dr. Sarvet co-founded the National Network of Child Psychiatry Consultation Programs and serves as its treasurer. Dr. Sarvet also co-chairs the Mental Health Task Force of the Massachusetts chapter of the American Academy of Pediatrics. Clearly an expert in this field, we are thrilled to have Dr. Sarvet presenting today. Alexis Davis is an independently licensed clinical social worker who has worked on the combined Tufts Medical Center Boston Children's Hospital MCPAP team since 2006. Ms. Davis has extensive experience working with children and families in a variety of settings with a focus on very young children. During her time at Tufts, Alexis was trained in another group model evidence-based parent training program called the Incredible Years. This model was financially unsustainable, which is why Alexis is so excited about the primary care PPP intervention, which is more successful due to its focus on the individual family and financial sustainability through billing. Dr. Sarvet, it's all yours.
Okay, well, thank you very much, Marcy, and hi, everybody, and welcome to this installment of the Clinical Conversations series. And so as Marcy said, we're really focusing on behavior problems in young children, particularly disruptive kinds of behavior problems. And by the way, I just want to emphasize that we're really interested in being able to really have a conversation on this thing. So please think about questions as you're going along, and we'd love to generate some discussion around questions that you have and case discussion if possible. So Alexis and I are going to start out by presenting some material to you, and so we're going to try to spend about half the time on giving you some things to consider, and then we'll open it up for discussion. So for the kind of presentation part, I thought we would just frame our time together. We're going to start, according to this slide that you see, talking a little bit about the general kind of perspective on how you approach behavioral problems in young children, and how to think about them, and how to sort out what your role is in addressing them, and also how to think a little bit about some of the factors. I want to emphasize that the majority of behavioral problems presenting in the primary care setting for young kids, it's not pathological per se. So we really want to emphasize this notion of trying to have almost like what we call a preclinical approach to dealing with these things, and so it really falls in the category of really prevention, mental health prevention, and I would say that in terms of the pathways to mental illness, one of the pathways is that kids, for a variety of reasons, start having difficult and challenging behaviors at a very young age. Those behaviors end up resulting in a lot of negativity in the parent-child relationship. And without the positive relationship between parents and children, it's very difficult for parents to really support the child's development, and things start going awry over time. And so you see this cascading kind of process of kids with behavioral problems resulting in really negative interactions and negative relationships with family members and parents. And then those negative interactions end up reinforcing all kinds of negative self-esteem, low self-esteem, different kinds of provocative behavior patterns. Certain negative behaviors are reinforced, and then before you know it, you start having generalization of those behavioral problems in the school setting, and then you have all kinds of issues of school failure, disciplinary problems, all of which feed back to reduced self-esteem, causing depression at times, causing patterns of antisocial behavior, and then so there's this unfolding. I don't mean to be so negative. I'm sorry for kind of painting such a bleak picture, but I really want to emphasize the importance of a preventive approach, because if you really catch these things early, you're not dealing with psychiatric illness. You're really dealing with behavior problems, and you can use different kinds of interventions early on that can really turn things around. And that's one of the reasons why we really feel so strongly, and we're so proud to have funding for being able to support the dissemination of P, because that really is one of these kind of primary care friendly intervention models that can start to turn things around before things become really pathological, where you need more formal and intensive, specialty mental health services and things like that. So in addition, we also want to talk about some of the psychiatric diagnoses, because it's not all prevention, and it's really good to keep in mind that there are certain early onset psychiatric conditions that can result in negative behaviors. Hey, Marcy, can you go back one slide? Thank you. And so we'll talk a little bit about the psychiatric conditions, and then we're going to move right into P, and Alexis is our expert on the call about P and lots of other things too, and so I think that we're going to shift over and have Alexis present on P, and then again we're going to go into our cases. Now we can go to the next slide. Thank you. Okay, so the concept of a parental child dyad is something that we talk a lot about in children's mental health, particularly for young kids, because when kids are very young, it's really not realistic to think about the child separately from the parent, especially for infants, but even for young children and preschoolers and kids up until middle childhood almost. But certainly kind of as a process of transition from being a dyad into being more of a autonomous individual, and then when adolescents start chomping at the bit to really be independent, they're still involved in a dyad or a systemic relationship in their family, but it shifts. But when we're talking about young children, it's really important to kind of think of the child in the context of their parental relationship, and I say beyond parent-child dyad and beyond, because it's really a whole family system, and it's not just the primary caregiver, but it's the environment, it's the social environment. Sometimes it's different kinds of extended family dynamics and community and issues in the building and neighborhood and in the home. And so the first step, when you're presented with a pattern of disruptive and negative, challenging behavior in a young child, is to take a step back and just acknowledge this child is part of a system. What's going on in that system? The first, actually, this list of bullets is, I listed them in this order because I think of it as a gradient almost from issues that are more prevention-oriented to things that are more treatment-oriented, where they're actually real kind of issues that belong to the child, lower down the list, getting to psychiatric disorders. But at the top of the list, I mean, the first thing to think about, because it's so common, is that you want to think about the parent, and the parent's sense of well-being and how the parent's doing in their own adjustment, to being a parent, and that ranges from issues of stress to mental illness, and so we don't have time to talk about the formal assessment of the parent in terms of their mental health, and you don't have time either in a primary care setting to do a formal assessment of the parent, but just to kind of think about and remind yourself that you're confronted with a behavior problem. The child, probably the first thing to think about is, how is this parent doing? And to ask a few questions about the well-being of the parent and how they're feeling and whether they're under a lot of stress and what kinds of challenges that they're facing personally. And so postpartum depression is very common, and it lingers when it's not treated, and sometimes gets worse. And it can really often, begin a cycle of challenging behavior in the child because of issues of attachment that occur in the context of the parental depression. They find it difficult to attach to their kids and difficult to give them positive interactions. They have difficulty tolerating the frustrations day-to-day of the parent-child relationship and helping to regulate the child's emotions. So that's a very common pathway to behavioral problems, is parental depression. But I also want to, again, emphasize that it's not all about pathology. Sometimes it's around parental stress without it being, a psychiatric illness in the parent. So that's the first question to ask yourself. Next question to ask yourself was, what is the ambiance of the family? Is there stress going on at home? And young children often mirror the stress, and they experience, the stress that's going on around them, and that often leads to negative behaviors, out of anxiety and frustration, and because those stressful factors in the family are leading people not to be as attuned to the child's needs. The third issue is temperament. That to consider that there's a range of, you got easy kids and you got difficult kids. That's kind of the one way of thinking about it. That they have kids who are very predictable, and their physiology is well regulated, and they are adaptable to change, and they're just easy to raise. And then you have kids who are more temperamental and more easily frustrated, have difficulty regulating their feelings, and their physiology is not as well regulated and predictable, so parents have a hard time. They don't sleep well sometimes. That's another aspect of related to temperament. And then you have issues about the fit between the parents. So sometimes you have kids who have more of an assertive kind of feisty style, and you have a parent who doesn't deal with that very well, that their personality isn't well suited. And so that's another factor that's not pathological, but that certainly can lead to challenges in parents' ability to manage, kids' behavior. The fourth bullet is really around, the fact that it takes a village, the family support that parents, have a hard time raising children, understandably, without having support from different kinds of resources around them in their community and in their extended family. And then they have different levels of skill. The expression, they don't hand out a manual. When you get a kid, from the hospital after you, come home, like there's no pamphlet, about how a user manual. So parents, need certain skills, and they may not have them. And so one of the jobs of a primary care provider responding to, requests for help or just, being informed of these behavior problems is thinking about, does the parent have a need to learn, more about, how to take care of a baby, and there's a lot of things that many people learn about development from their own parents and from extended family, grandparents who are around, and other people who teach them, and also, skills that are related to ingrained habits of how you kind of relate to children based on the way that you were treated as a child. So that's not really a skill issue, but it's around the fact that we all develop these kind of internal working models as to how to deal with other people, based on the way that we were treated as children. And sometimes if we don't have good ones because we weren't treated well as children ourselves, then these skills don't come naturally. Whereas if we're treated really well in our childhood, then it's very easy to learn, the good skills because they're sort of baked into your brain in a way. And then the last two issues are, constitutional factors. Sometimes kids have the hearing impairments, developmental delays, and communication delays that make it hard for them to kind of learn and to go along with expectations and to understand expectations. And that can lead to behavioral problems, and then you can have that sort of initiation of the vicious cycle that I talked about before. And then finally, the last part is that there is psychopathology that sometimes is brewing, when you're presented with a behavioral problem, and that we'll talk about that in the next slide. Marcy. There you go. Okay, thank you. So just like really briefly, and I want to hand it over to Alexis like very soon, to just mention that of course, ADHD and ODD are disruptive behavior disorders. They're psychiatric, conditions in the DSM-5, and that's one of the things that you need to consider. And just to kind of let you know, I think most people know how to assess ADHD, but that ADHD is something that often begins to manifest itself around age 3, and it may be diagnosed at that time, or maybe diagnosed 4 and 5. It's good to try to make the diagnosis as early as possible. That there are criteria that are easy to apply and that are organized pretty well with the Vanderbilt rating scale. And then there's a need to consider, other factors that could cause a patient to appear to have ADHD that aren't really ADHD. ODD is actually something that's a persistent pattern of negative behavior and defiance and resentfulness and kind of negative emotional qualities in kids that lead them to challenge their parents and always be dissatisfied. The kids with ODD are kind of always, nothing is ever good enough, and they're always angry and often can be vindictive, and then they have a pattern of rule-breaking behavior. But the key with ODD is that it has to really go on for at least 6 months. So it's really a persistent quality of negative and oppositional behavior, and it can be and should be diagnosed as early as possible, and that requires more formal treatment. ASD stands for Autism Spectrum Disorders, and people are aware of some of the screening instruments that the Mass Health program covers through the CBHI initiative for that, and that's a relatively high prevalence issue that we need to keep in mind all the time, and it kind of goes beyond the scope of this talk. And then finally, PTSD. I think the biggest difference with PTSD is that of course you have to have the trauma history, and whenever you're looking at all these factors, you need to consider the issues of questions of environmental stress, as I said before, but sometimes those environmental stressors really are tantamount to trauma. And so you're gathering a trauma history. If there is a trauma history, when kids have PTSD, they often have emotional dysregulation and behavioral dysregulation, and often that dysregulation is triggered. So certain circumstances will bring out these explosions of negative behavior, and it's not necessarily going to be as persistent and consistent a pattern as you would see with ADHD. But with early childhood trauma, sometimes there is this chronic dysregulation that can be very difficult to tease out from ADHD and ODD. But I think the key is that you're looking for that trauma history. Next slide, Marcy. So finally, I guess just really briefly, when you're putting together a treatment plan, you have to consider, after you've done all this reflection and considering the different factors that we talked about, you want to tailor the treatment plan to whatever the issues are. So sometimes you need to make a plan for really a parent-focused intervention, especially if there are issues of parental stress, parent skill deficits, issues of kind of fit, temperament, relationship issues. All those really kind of call for a parent intervention, parent-level intervention. It's not going to be that useful to send the child into psychotherapy to do play therapy in those instances, and you want to do, at the very least, a parent intervention, if not, a dyad treatment where the parent and child, come both. But I think the point I want to make in this slide is that when you're kind of leading into a referral or some kind of treatment plan for a parent intervention, the approach and the way that you pitch that is pretty important, because almost always when the parent is bringing you the child, they're saying, there's something wrong with my child and I need your help with this thing that's wrong with my child. And the key is to try to pivot that into saying, in a very respectful and non-judgmental way, that you would like them to actually have some help with the parenting side of the equation. And it's very easy for people to feel blamed and insulted, offended, disrespected when you make that pivot. And so I think that I don't have a formula for how to do that, but I think the key is to really recognize and acknowledge that it's a high-risk kind of move, because you risk alienating the parent and actually making them feel guilty about it. So you need to go out of your way to be really respectful of them and have ways of framing the referral that would lead the parent to understand that you're not telling them it's their fault, but that you're suggesting to them that there are certain kinds of techniques that could be very effective in helping them to manage this challenging behavior in their child, as opposed to saying that the child's acting out because you're not doing the right thing and we need to fix you, even though you said that you wanted us to do something to fix the child. And so that's kind of the trick of it all. And so I think with that, I'm going to hand it over to Alexis.
Hello. All right. Thanks, Dr. Sarvet. So let's talk about Triple P a little bit. Triple P is a multi-level system of family intervention. We're going to be talking specifically about the level 3, which is the primary care level, but it is a 5-level intervention of increasing intensity and different specificity. So there are some that focus on teenagers, or some that focus on developmental disorders. Providers are trained and accredited in each specific level. So I'm going to be talking about primary care triple P because that's all I'm trained and accredited to provide. But it is designed at all the levels. It's designed as an early intervention for parents, particularly in this level, to address common developmental or behavioral difficulties that their children have. And it was developed out of research at University of Queensland, so it is evidence-based. I think it's being used, correct me if I'm wrong, but I think in 98 countries at this point. So it's definitely gotten its way around, and as Marcy mentioned earlier, I had previous training in another model which was also evidence-based and wonderful, but not as individualized. And so in that respect, this model works a little bit better. Can we hop to the next slide, please? Okay, so MCPAP offers, so why triple P? So triple P was chosen because, well, the need for something like triple P developed out of, I think, everybody's understanding that young children are a good area to put funds into and to focus on, because if you catch these problems early, they create less problems when kids get older as far as the mental health system as well as kind of the school system. So that's why the need for something like this. And I think MCPAP chose the level 3 primary care triple P because it aligned so well with the MCPAP mission of supporting primary care providers with mental health and behavioral health problems in the primary care setting. And as the world develops into a medical home type of model, I think triple P really works well with the co-located or integrated behavioral health settings that we have. As Marcy mentioned, one of the reasons I like this model of parent training is because it is sustainable through third-party billing, because you're working individually with families, so you can bill as a family, basically as a family session. So this model is targeted for children birth through age 12. Again, as I mentioned, there are different levels of triple P, and there are some that are focused on teenagers and and different areas of trouble. But this one is best used with children birth to age 12. So overall, and this applies amongst all the levels of triple P, the principles of positive parenting are having a safe, interesting environment, the idea being that if kids are bored, they are more likely to get into mischief. Having a positive learning environment, using assertive as opposed to aggressive discipline styles, having realistic expectations, and I think that's particularly important because a lot of people don't understand developmental norms and may be expecting, say, their 2-year-old to do something that is never going to happen, and everybody's frustration level will go up if you're not setting realistic expectations. And then taking care of yourself as a parent. I think one of the things that we like to say to people in getting them invested in doing a program such as Triple P is that the goal of it is to make parenting easier and more enjoyable. And how can that sound bad to anybody, really? All right, next slide. So the skills promoted through Triple P. Developing a positive relationship with children, and so that's a lot of how to play with kids, and that may sound very basic, but I think people don't always know that letting kids be child-directed in their play is really useful, and allowing kids to sort of let you know what they're thinking and be creative and do things their way, because so much of the world is rules that are imposed upon them. So just having an open, playful relationship with kids and developing that kind of rapport. Encouraging good behavior, and so that's through obviously modeling and making sure that parents are modeling the behavior that they want to see through their own behavior and actions, as well as praise. And making sure that you're catching the child being good. So if they're doing something you want them to do and you don't comment on it, you're not going to see that behavior replicated too often. Teaching new skills and behavior, and so that focuses on helping parents to make sure that they're setting clear limits, that their rules are appropriate and developmentally appropriate, and are understood, being framed in a developmentally appropriate way, and setting limits in a clear, calm manner. And then managing misbehavior, that's, things like taking away privileges or desired toys or games, and then of course timeouts and things like that, which one thing that I have found is that often parents come to me saying that timeouts don't work, and in fact they have not been doing it correctly, and it seems so intuitive, but there's better and worse ways to give timeouts, and so we can help parents to give them in a way that they're more useful. And then enhancing self-regulation and promoting confidence, and again that speaks to having being able to have a more enjoyable experience as a parent. And the more confident you feel in your effectiveness as a parent, the better you'll feel about the experience. All right, next slide, please. Okay, so primary care Triple P is delivered by a Triple P accredited behavioral health or medical provider in a primary care office, or delivered by a Triple P accredited MCPAP hub therapist or a nurse practitioner at the hub. And it takes place over 2 to 4 sessions, each lasting between 30 and 60 minutes. So because it's all at a primary care level and it's meant to be sort of an early intervention, it has to feel doable to the parent. So if you tell them, oh, here, we'd like you to participate in this program, or would you like to participate in this program, you have to commit to 10 sessions or 20 sessions. That doesn't feel very sustainable. So these are regular length sessions, 30 to 60 minutes, and it's designed over 4 sessions, but it can be sort of consolidated into as little as 2 sessions. And then remember that MCPAP is insurance blind, so in our particular case, that shouldn't be an issue, an obstacle to getting people into treatment. Okay, so primary care Triple P, the 4 sessions. The first session is an overview or assessment of the presenting problem. You want to make sure that Triple P is the right intervention, and that the parents understand what it entails. As Dr. Sarvet may have mentioned earlier, it's not therapy for the parent and it's not therapy for the child, and it's really a way to sort of provide skills and tools that will make the parent more effective and therefore make the experience more enjoyable. So that will include some, family history of the problem, that kind of thing, but not as in-depth as it would be if you were doing a mental health evaluation. Session 2 is about developing a parenting plan. So at session 1, they go home with a plan to track the behavior. They choose a method of tracking, and they track the behavior over the course of the week, and they come back and they talk about how that went, and then how they want to intervene. Triple P is great because they have designed tip sheets, which pretty much cover any behavior you could possibly imagine, and then they have a sort of a blank format or formula for how to do one that they haven't come up with. But so basically what you're talking about with the parents is what would improvement look like, and what would you like to see, and then you choose a tip sheet, and it sort of lays out ways to manage that behavior, both as far as preventative ways to manage the behavior as well as how to handle the situation after the behavior has occurred. And so again, the parents go home with the tracking information, and now they implement their plan and continue to track the behavior, and then they come back for session 3 to talk about how that went, and what improvement did they see, what went well, what didn't go well, you know, how do they need to tweak it in order to see greater success. And then typically session 4 is 3 to 4 weeks later, and they've had a longer stretch to see how their interventions are helping the child and what additional things need to happen. At this point, they can, if they feel like that behavior is well controlled, then they can choose to start over with a new behavior. But in my experience, that's never been necessary, because the parents find that the tips that they use and the interventions that they use to address the first behavior are easily adaptable to other behaviors, and they often do so and find that those behaviors improve as well. All right, next slide. All right, so who to refer? Parents of children birth to 12 with mild to moderate behavior problems, which are not necessarily mental health problems. So that could be anything from bedtime or morning routine struggles to something like anger issues that don't rise to the level of being a mental health problem. And or parents that want or can benefit from some parent coaching, such as new parents or parents that are lacking confidence in their skills, which I think you guys probably hear a fair amount, just parents who, when they talk about their experience, just sound like they don't feel very confident, and they don't feel like they're doing the job that they want to be doing. Primary care is not appropriate for children with severe behavior problems or severe developmental issues, and it's also not appropriate for parents with active substance abuse issues or mental illness. All right, so excuse me, how to refer. So when you're talking with a parent or caregiver about a referral to Triple P, we want you to refer to the intervention as coaching or training on managing challenging childhood behavior, and as an opportunity to learn more about typical child development, and again, as I've said before, a way to make parenting more enjoyable. The reason we don't want you to refer to it as a skills training is because often parents come in as defensive, that they're doing something wrong, and that's not at all the case. One thing that I like about it is it's for parents who are in most ways doing a great job, and either their child's behavior is particularly difficult, or there's just something about the dynamic that isn't working and might work better. In fact, one example, which we'll talk a little bit more about examples in a few minutes, but one example is a parent whose first child they had no problem managing, and their second child is maybe strong-willed or something like that. So they have the skills already to manage your average child, but this child is particularly challenging in some way. So we don't want them coming in with that defensiveness. And then the other thing that's important is to make sure they understand that it's not therapy for them or for the child. That is a separate entity, and it doesn't mean that a child might not also need therapy in addition to Triple P, or that the family may not need family therapy in addition to Triple P, but this is a separate intervention. So it's intended specifically to help them manage their child's challenging behaviors. So to make a referral to Triple P, you can have the parents call, or you can call your local MCPAP hub, the care coordinator or the therapist. I believe at this point all of the MCPAP hub therapists are trained, or at least there is a trained therapist in each. So if you have questions about the program before you make a referral, you can call the therapist, or if you know you want to make a referral, calling the care coordinator would be appropriate as well. And I guess next slide, if you have any more questions about Triple P, you can visit their website. And if you are interested in getting more information about referring, you can check out the MCPAP website and click on the Providers tab. And there's a sheet, an information sheet included there. So we wanted to leave some time.
Oh, thank you, Alexis. I was just going to say, this is a time that we'll have for discussion and questions. One thing I want to mention, this is Marcy again, is that, we're very grateful to both the Department of Mental Health and the Department of Early Education and Care, who provided the funding through a Race to the Top grant that the state received in order to enable us to provide the training for primary care Triple P. I know we probably have about 53 providers across the state that are trained in primary care Triple P, including someone at each of our hubs, but many of the folks are actually working in primary care offices or in behavioral health organizations that co-locate part-time in primary care offices. So we're very grateful to those folks for providing the funding for this, and to Sandy Wickstead at the Department of Mental Health, who helped make this happen. It was definitely a collaborative effort. So I don't see any questions right now. Well, we did have one question. What does Triple P stand for? I'm sorry we didn't manage to say that from the beginning. It's Positive Parenting Program.
One of those things that seems so obvious that we left it out completely.
Okay, so some questions are coming in.
Alexis, before we do that, I just was going to ask, Alexis, did you have in mind any particular example cases that we would present, or are we going to be fielding cases from the audience? Primarily.
Yeah, so I was just going to mention a couple just examples of cases, not necessarily talk about full cases, but so I think one that I just mentioned was something where the parent managed fine with an older child, kind of thought they had, and then their next child is particularly strong-willed and they're just really struggling. Or another example would be a kid where the parent describes them as the Energizer Bunny and constantly moving and constantly in need of attention and things like that. So that might be another example of a kid a parent that could benefit from Triple P. And then, as I said throughout the presentation, things like specific times of day that the kids struggle, so bedtime or morning routines, or if there's a specific thing that a parent mentions to you, that's a perfect example of something that they're struggling with. That's a perfect example of something that could be dealt with through Triple P. And again, a lot of times parents come with many behaviors in mind, but find that if they pick the thing that to work on it during the course of the sessions that's the most troublesome, usually they can find that those same interventions and those same strategies work to manage other behaviors as well.
Great. And another point I was just thinking about is that even though we're especially focusing on Triple P in this webinar, the title really is more general, that we're talking about managing behavior problems in young children, helping children with disruptive behavior in general. And I guess one thing that I often bring up, and it comes up a lot in telephone consults through MCPAP, is it's around what to expect of actual therapy referrals or therapists, because triple P is not therapy, but sometimes depending upon how severe or whether it's associated with a psychiatric illness, you'll be referring patients to therapy. And I did mention in passing that for young children, that we really believe that every therapy or every therapist who's treating a young child needs to be devoting a substantial portion of their time to working with parents on interactions and parenting, parent skills, and behavior management strategies and things like that. And so if you have a child in therapy, I really feel like a triple P referral may be redundant. It depends, but I think the first step is really to check in with the therapist to find out whether or not the therapist is actually providing this kind of help. They may not be doing triple P, but they really that this is an important component of treatment for any child with behavioral problems, regardless of diagnosis. And I think it's important for PCPs to really know what they should expect from therapists, so there can be some kind of accountability and sort of a coordination role. And so a lot of times I hear from PCPs that they understand that a child is in therapy. It might be a 4-year-old or a 5-year-old, and they know that and they have the belief that the child is just receiving some kind of individual play therapy, and the parent does not even know what's going on. And so I think that's kind of a sign that there is a problem in that provision of care. And as a PCP, I think you have every right to inquire, and to recommend, that there be a parent sort of approach in the treatment, and it's kind of a way for pediatricians to kind of have a quality control kind of treatment coordination role, with these cases. So let's go on.
Thank you, Barry. We have a few questions. The first question is, do parents come to you for this program, or do you go to their home? Is this done in a small group setting or one-to-one? Alexis, you want to take that?
Sure. Parents come to us, and I think that's true in every situation, right, Marcy? That's how the non-MCPAP people manage it too. Okay, yes. So they come. It's an in-office thing, but yes, it is individual with that family as opposed to a group setting.
The next question is, what diagnosis is used for billing for the family session?
That has been tricky, I will be honest, and I'm not sure that everybody is doing it exactly the same way. The way we've decided to do it at Tufts is that we get the parents' permission to bill under them, because oftentimes we don't even meet the child. If I meet the child, if I don't know that I'm doing triple P, if that comes up sort of in the context of doing a general intake, then I will bill under the child. But if we know that we're going directly to triple P because of a referral from a primary care, then I get the parents' permission to bill under them, and it gets billed as a family session, but the diagnosis code is an adjustment disorder. And in every situation, I tell the parents that up front and ask their permission to do it that way.
Now, what if, Alexis, what if the parent doesn't feel comfortable, with the idea of them being the patient, because they've brought their child and they feel like this is sort of meant for their child?
To be honest, I haven't run into it yet.
Okay.
But what I would do then is I would just make a point of meeting the child, because you can do a family session without the patient there, and then so long as I've met the child, then that child can be my patient, and I can do a session with a family without the child there, or multiple sessions, and then I just bill it as a family session with the patient not present. And it gets billed under a diagnosis for the child. And again, unless there's an obvious diagnosis, that too gets billed as an adjustment disorder, typically.
Great, thank you. Next question, how could we go about having a PPP certified provider come to our office? Many of the families we would refer would not be able to drive the 90 minutes to our nearest hub. So I can answer that. Actually, assuming that you're making the referral to your hub, MCPAP is going to be implementing telepsychiatry very shortly. We're going to be piloting it, starting with the Bay State hub in Western Massachusetts, starting in late January, early February. And so the PPP accredited provider at the hub would be able to do this via telepsychiatry with the family or with the parents. Unfortunately, we wouldn't have the capacity to have folks come to the practice, you know, to not being able to have them come to the practice for face-to-face visits, you know, or consults that we do for MCPAP, which is why, you know, with today's technology, we're really exploring the ability to implement telepsychiatry. The next question, which is an excellent question, is if the family's first language is not English, can they benefit from PPP? Alexis? Do you want to answer that?
Yes, they can. However, I think that this probably varies pretty substantially from location to location. So what I would say is that for our location, we have being a major teaching hospital, we have a fairly extensive interpreter services department. However, it can be, depending on the language, quite slow to get an appointment. That said, other locations, I know you can get any language with 24 hours notice. So I would say that that would really depend on where it's happening. And then, of course, anytime you're working with an interpreter, there's a little bit of a barrier as far as the clinical treatment. But yes, they could definitely still benefit doing it with an interpreter.
So I do know that some of our other PPP providers in a couple of the community health centers have used PPP in a variety of languages. There's a video that's used as part of the 4 sessions that's very powerful, and it does come in a variety of languages. And some folks have used interpreters as well. So you know, again, it is doable, and it has been implemented in 98 countries, as Alexis said. So it's certainly applicable for non-English speaking parents and folks of other cultures. You know, we know that there's cultural differences as well, but it seems to be pretty universally applied, or applicable, I should say. The next question is, if a provider wants to refer to PPP, but the family does not want to go to the MCPAP location, is that still handled by MCPAP? So here's how this works. Folks that were trained in primary care PPP work in specific primary care locations. So if you don't have a co-located or integrated behavioral health clinician or a medical provider in your practice that has been trained, then your only option at this point is to refer to the hub. There are a couple of behavioral health organizations that have primary care PPP providers that are trained, who work part-time in primary care practices and part-time in their outpatient behavioral health clinics. And if you are interested in finding out if there's one near you, you could certainly email us at mcpap@valueoptions.com. That's our general MCPAP email, and we can provide you with that information if there might be a provider at a behavioral health organization near you. Okay. Oh, and I have, in terms of the billing, we had another participant let us know that in general pediatrics, we can bill 99215 for behavior problems in the child's name. So that's if the triple P is being provided by a medical provider. And we did train a few PCPs in the primary care triple P who are providing the intervention during their either, they identify it during their well child visit and have the family come back. So that's worked out really well also. Do you bill for telepsychiatry services? No. So for our MCPAP telepsychiatry services, I can tell you what we know right now is that as of today, there is no billing for telepsychiatry services for commercial insurance. For Mass Health, it's only for actual psychiatry, not for therapy. So the triple P intervention will not be billable through any payer, through telepsychiatry. Who can be trained in triple P and how can a training be set up? Excellent questions. So basically anybody can be trained in triple P. We actually trained a couple of CBHI family partners through our trainings, as well as behavioral health clinicians and medical providers. The grant that we received is ending at the end of this month, so we will not be providing any additional primary care triple P trainings. Triple P does have something they call open enrollment, where you can go on their website or you can call them and ask if there's an open training anywhere nearby that you could sign up for. And then I think what happens is if they have enough demand in a particular area, they'll set one up. They haven't had any open trainings in Boston or in the Boston area, but they might, because I think we're creating a demand, that would be how that works at this point. Next question is, are there any opportunities for provider training with triple P? I think we just answered that. Let's see. Oh, yes. I wanted to mention that all the materials are available in Spanish, and some materials are available in other languages as well. I know we have the DVD in Arabic and Portuguese and Spanish. I know the tip sheets are in Spanish and Portuguese and some other languages, but not always ones that we in Massachusetts might want them to be in. So there is still a need for interpretation and translation from time to time. Oh, someone just let me know the parent triple P website has a location finder for triple P providers. Thank you. I didn't even realize that. So that's good to know. So that's the end of our questions, I believe. I'm just double checking to make sure no more came in. And I want to thank everyone for participating in our webinar today. Just as a reminder, we hope you'll take 60 seconds to fill out the very brief survey monkey that will come up at the end of the webinar. And I want to thank Dr. Sarvet and Alexis Davis for presenting today and sharing their expertise on this topic. And remind everyone that this recording will be available on our website within about 24 hours, and that our next clinical conversation will be on Tuesday, January 19th, same time, 12:15 to 1:15, focusing on postpartum depression screening in the pediatric setting.
Well, happy holidays, everybody.
Oh, I'm sorry, January 26th. That is incorrect. The next clinical conversation is on January 26th. I made a mistake. Okay. Thank you.
All right. Thanks, everybody, for coming.
Thank you.
All the best. Bye-bye.